Now we will shift to the third session. The chairperson now ready?
Yes, ready, Professor.
We have Professor Dr. Ahmed Nagih, Professor Amin Al-Banna, Professor Walid Al-Shazli, now ready for the next session. Go on. Dr. Amini, go on.
Yes, Professor. It's an honor to be with you in this prestigious IBD edu. Nice to meet you, Professor Hussein Al-Amin and Professor Ahmed Nagih and Professor Walid Al-Shazli, but I don't know where is Professor Walid. Is he with us?
No, I think Professor Salim is ready now.
Okay, so it's an honor now to introduce Professor Salim. I don't know.
Salim Ishtawi from Libya.
Salim Ishtawi from Libya, to give us a lecture on the post-operative Crohn's disease management between guidelines and clinical experience. Yes, Professor, we have the honor to have you having you with us. Please.
مساء الخير جميعا. سامعين الصوت؟
تمام سامعين.
تمام. أعتذر عن عدم وجود الصورة. I have some technical problems with the camera. بس أي حد يعني ما عندوش شعر تبص عليه وأنت تعرف إني أنا يعني.
أكيد عارفينك وكنت لسه منورنا الجمعة اللي فاتت بروفيسور.
الله يخليك. I'll share my slides now. Okay, so we're starting. So what I'm going to do today is talk about post-operative Crohn's disease. So I'll define the scope of the problem, and then we'll go through some of the guidelines. So we know that post-operative recurrence in Crohn's disease is a common problem. Almost half or more of patients will require surgical resection within the first 10 years of the disease, and quarter of these will require at least another resection within 5 years. Now, the endoscopic recurrence at the terminal ileum can occur in up to 90% of patients within 12 months of the first surgical resection. However, the clinical recurrence lags behind. That's why if we look at here, we see that within the first week, you can see histological recurrence. 70 to 90% of patients by 1 year, they will get endoscopic recurrence. We have to intervene in this period here. Once we see radiological features of recurrence or clinical recurrence, then it's probably too late and the tissue damage has occurred and the patient might progress to surgery. So I'm sure that you all are aware of this endoscopic scoring system, which Rutgers developed for post-operative recurrence staging. So if the patient has I0 or I1, then they are in endoscopic remission. If they have I2, 3, or I4, then they are in recurrence and they will need some sort of prophylaxis. Now, around 70% of patients at 1 year will have either I2, 3, or 4 during endoscopy, and therefore they are at risk of progressing to surgery. Those who have I0 or I1, they are the likelihood that they go to surgery is low. Now, so what are the risk factors for post-operative recurrence of Crohn's disease? There are many risk factors: patient-related, disease-related, surgery-related, histology-related, and gene-related. The patient-related factors are many as well. Smoking is one of the most important ones. Sex, young females probably are more, but no concrete data. IBD, family history, unclear. Then we come to the disease-related. young age at onset carries high risk of bad Crohn's disease in general, and probably post-operative, but no clear data in this setting. Duration before the first surgery, of course, short duration before the first surgery is related to high recurrence post-operative. The location of the disease, so the ileocolonic disease is less than the ileal disease in terms of recurrence. And the penetrating phenotype of disease is more aggressive and more related to post-operative recurrence compared to stricturing or inflammatory disease. The perianal disease carries a high risk of post-operative recurrence as well. Now, the type of surgery also have some implications. So if the whether you do it with stapler or you do it hand sewing, whether it's a wide anastomosis, whether you keep the patency of the bowel or you make a preventive or prophylactic ileostomy. The extent and margins of the recurrence, if you excise more than 50 centimeters of the small bowel, then probably that's an indicator for early post-operative recurrence. There is no data whether laparoscopic or open surgery have any difference. And structuroplasty, some studies say that there is high post-operative recurrence with structuroplasty. Post-operative complications, not clear. Blood transfusion, yes, increases the risk of endoscopic and surgical post-operative recurrence. And having previous resection is a risk factor as well. Now, the histology-related factors include plexitis. So if you see myenteric plexus, then that's a predictive of early and severe post-operative recurrence. Presence of granulomas as well is associated with high recurrence. Lymphatic vessel density, it's inversely related to the post-operative recurrence. Gene factors, the most important gene is SMAD, is NOD2 or CART15 gene, which increases the risk of post-operative recurrence. Other genes are also implicated, but no clear rule for them. Now, if you look at this, this is simple stratification of the original guide to the stratify patients into low risk, intermediate risk, or high risk group. And usually in the low risk group, probably prophylaxis is not needed if the patient is willing to go that way. In the other two groups, prophylaxis is needed. So what medication we can use and why? This table shows different studies that compared anti-TNF-alpha medications with azathioprine and 5-aminosalicylic acid group and also with placebo. And you can see from the results here that anti-TNF-alpha had much better impact on post-operative recurrence prevention. These studies, most of them stopped after 12 months. However, the Yoshida study had follow-up at 3 years, and there was significantly higher remission rate of 93.3 on the infliximab side compared with 56.3 on no treatment side. So still at 3 years, there is benefit. There's a randomized study that compared post-operative Crohn's disease using adalimumab against azathioprine or 5-aminosalicylic acid for 2 years. And at 2 years, they found that there was a significant reduction in endoscopic recurrence for those on adalimumab compared to azathioprine and 5-aminosalicylic acid. This graph here shows the effect of infliximab compared to placebo, and again, impressive patients remained in remission. So the post-operative recurrence in the placebo group is 51%, and in infliximab group is 22%. Now, for those patients who was receiving anti-TNF-alpha prophylaxis, after the surgery will predict that they will have more relapse compared to patients who didn't receive anti-TNF alpha before having their surgery. Now we look at the PUSAR study. Now 50% of patients were put into the standard care group, so they had no endoscopy at 6 months, and 50% of patients had endoscopy at 6 months, and they were called the active care group. Now the treatment was escalated in the active care group depending on the endoscopic Oret grade score. So if they were on no treatment, they will receive azathioprine. If they were on thiopurines, then they will go into adalimumab. And if they were using adalimumab, they will escalate the dose or decrease, the dose interval. Now, at 18 months, the active care group, they still have 49% of recurrence, whereas the standard care group, 60% post-operative recurrence. So significant difference, but still high figure, 49% group here. So we are not doing excellent here. So at 18 months, clinical recurrence was 27% in the active care group and 40% in the standard care group, and the statistics were not significant. Now, if you compare the anti-TNF alpha with thiopurines, obviously here that adalimumab causes more remission, and there was less post-operative recurrence compared to thiopurines. Sorry. And there was no difference between infliximab and adalimumab in endoscopic, preventing the endoscopic or histological or even the clinical post-operative recurrence in Crohn's disease. What about antibiotics? Now, antibiotics, the widely used one is metronidazole, and it usually prevents post-operative recurrence at least for the first 3 months. There are lots of limitations for its use. The adherence to taking it is not great, and it is associated with peripheral neuropathy for long term, so usually given in the first 3 months. Ciprofloxacin doesn't have much effect, and there is increased interest now in using rifaximin for post-operative recurrence of Crohn's disease. So what the BSG guidelines say? So they suggest that following ileocolonic resection of Crohn's disease, we have to assess mucosal inflammation, either by ileocolonoscopy, fecal calprotectin, and or cross-sectional imaging, if ileocolonoscopy is not possible or not acceptable. But these are not as sensitive enough to detect the localized inflammation. They suggest that the ileocolonoscopy is done at 6 months to assess the new terminal ileum, and if it's not at reach, then we go to cross-sectional study with MR enterography to assess the new terminal ileum. The BSG also suggests that Crohn's disease patients with significant risk factors for disease recurrence following ileocolonic resection, especially if they are smokers, they should have, at 6 months post surgery, they should have colonoscopy, and they can be started after with thiopurines if they have recurrence. Those who are not tolerating thiopurines, they can go into anti-TNF alpha. They recommend that some patients who don't have endoscopic recurrence, but who has diarrhea, they have to be investigated for other causes of diarrhea, like bile salt malabsorption, and a trial of cholestyramine should be offered. If cholestyramine trial didn't work, then we might consider a CCAT study. BSG recommends that all patients should quit smoking, and they advise against the use of mesalazine in post-operative Crohn's disease. Now, the AGA goes a bit more proactive. So they advise to use pharmacological prophylaxis immediately after surgery rather than endoscopically guided pharmacological treatment. In patients with surgically induced remission of Crohn's disease, they suggest using anti-TNF alpha and or thiopurines over other agents. They also advise against use of 5-aminosalicylic acid, budesonide, or probiotics. In those patients who had surgery, whether they are receiving or not receiving pharmacological prophylaxis, they suggest that post-operative endoscopic monitoring should be done at 6 to 12 months to assess the new terminal ileum. In patients with surgically induced remission of Crohn's disease, asymptomatic with asymptomatic endoscopic recurrence, they suggest starting or optimizing anti-TNF alpha or and thiopurine over continued monitoring alone. So I talk here about a little bit of non-invasive methods to evaluate post-operative recurrence. So ileocolonoscopy is the gold standard, but ECHO says that you can use calprotectin, transabdominal ultrasound, magnetic resonance enterography, and many other emerging alternatives. So I don't have enough time to go through these, but I'll just say that fecal calprotectin is correlates well with Rutger's score, and it doesn't replace colonoscopy, but in low risk group, if you measure fecal calprotectin at 3 months after surgery, if they are positive, you might consider doing early colonoscopy. There is increased interest now in the microbiome and the presence of Proteus in the resection margin, which increases the recurrence. If you have reduced Fecalibacterium prasinetzi, then that's again another factor. So briefly, we have low risk patients or patient preference, then probably no medications or metronidazole for the first 3 months, then colonoscopy at 6 to 12 months. If they have no post-operative recurrence, then repeating in colonoscopy at 1 to 3 years. If they have recurrence, then they have to receive anti-TNF alpha and or thiopurines. If the high-risk group patients, you straight away start anti-TNF alpha according to the AGA and metronidazoles for the first 3 months. Of course, you would stop smoking. BSG adopts something similar, but before discharge of the patient, they start him on metronidazole for 3 months and ask them to stop smoking, and then they stratify the risk. If they have low risk factors, then they do ileocolonoscopy at 6 months. If they have high risk factors or likely to continue smoking, then probably you start them on thiopurine, or if they are intolerant, you start them on anti-TNF alpha agents. So what we do here in our country, it's really problematic here due to lack of data on prevalence and incidence. Many patients are diagnosed overseas, either in Egypt or Tunisia, and many of them go for follow-up there. So no good data regarding epidemiology of the disease here. In a hospital-based study that was published in the Libyan Medical Journal last year, that included 263 IBD patients. 100 patients of these had Crohn's disease, and 27% of these patients had surgery. And all patients were on medical prophylaxis. So what we use, options are limited really by the drug availability, especially during the last 10 years due to political unrest and the civil war. So one day you have everything, one day you have nothing. So we commonly use thiopurines. They are the mainstay of management, and we keep anti-TNF alpha for the high-risk patients because we don't have too much of those. And if you just I hope that everyone here is is understanding, but even the types today, you have the originator, for example, Remicade, and tomorrow all of a sudden the supplier will bring you a biosimilar, and the next month you will have the originator again, and you never hear about shifting patient from biosimilar to originator, but it happens in Libya. Unfortunately, some doctors here are still using 5-aminosalicylic acids for Crohn's disease, and I'm sure this will stop very soon. So in conclusion, post-operative recurrence is a very common problem, and it's important to start early prophylaxis and treatment so that we don't reach tissue damage and surgical remission, surgical recurrence. Risk stratification is very important and should guide our treatment to safe resources. All patients should be encouraged to stop smoking. Anti-TNF alpha is the best therapy to date as prophylaxis after surgery, and it's used in the high-risk patients. Early endoscopy, 6 to 12 months after surgery, should be used to guide future treatment. We have to escalate treatment based on endoscopy, and the difficult patients should be discussed in MDT meeting with the surgeons and the radiologist, and to discuss with the patient as well about their preference. Thank you very much for listening.
Thank you very much, Professor Salim, for this very nice and demonstrative lecture. And now,
thank you.
We have a question. Yes.
Is there any question from the floor?
I have a question too.
Yes.
Professor
Thanks,
Abir.
Professor Salim Shtawiya, for this nice presentation and very illustrative in just many slides, helping us and taking the algorithm for the use. But I have two query about if the patient refuse colonoscopy and he's at high risk from the start, and you know that there is now more data about use of luminal or gut ultrasound for assessing the patient can play a role in post-operative recurrence assessment. That is the first question.
Thanks, Professor Azat. I'm sure you know better regarding endoscopic ultrasound. Unfortunately, we don't have it here, but endoscopic ultrasound plays a role, up to my knowledge, in perineal disease and fistulating disease. Rather than
just abdominal ultrasound for gut.
Sorry. Yeah. Abdominal ultrasound, just conventional transabdominal ultrasound, you mean?
Yes, that is.
Yes. Well, depending on the experience, in experienced hands, transabdominal ultrasound plays a role now in follow-up. And if the patient is not willing to have colonoscopy, then endoscopic ultrasound, transabdominal ultrasound has to be used, or alternatively, MR enterography can be used as well.
The second question about the treatment. You know that all the studies depend on anti-TNF, especially infliximab, in post-operative recurrence. Do you think there is a good data about use of ustekinumab or vedolizumab in treatment post-operative recurrence?
Not up to my knowledge now. Ustekinumab, vedolizumab, and vedo, they don't have good data in the post-operative setting.
Okay, thank you.
You're welcome. Thank you.
Professor Abir.
Dr. Salim, thank you for this updated lecture. Very important topic. I'm asking about the role. Anyone studied the role of methotrexate post-operative as ileocecal involvement? We have another option, which is methotrexate, especially if we have extraintestinal manifestation, ileocecal Crohn's disease, can respond لميثوتراكسيت. What about post-operative?
The short answer is I don't know. I didn't come across good studies in this regard.
Okay, I had a question, Professor. I actually had a case, and I want to consult you about this case. The patient was about 37 years old, and he presented with appendicular mass, and by investigation, it showed to be ileal Crohn's with abscess formation. He was drained with ultrasound, and he was given strong antibiotics, and he was assessed and started treatment after ileocolonoscopy, which showed that the patient has ileal Crohn's. At this stage, would you suggest surgery for the patient? I hope this question is not out of the scope of the lecture, but I mean a real-time case.
Nice. So this patient is 37 years old, and
Yes.
This is the first presentation, isn't it?
Yes, this was his first presentation.
Yeah, I mean, if the patient has ileal disease and she doesn't have fibrotic stricture and it's inflammatory, I would go for biological treatment, mainly anti-TNF alpha, rather than considering surgery, unless MRI shows that there is pre-stenotic dilatation or she has obstructive symptoms.
Yes, but many of the paper I read, they said that if the patient has exclusive ileal disease, you may go for surgery.
Yes, of course.
Yeah.
It depends on who's talking. If it's a surgeon, they would advise to go to surgery, especially if you have, they call it limited ileal disease. But again, we know that surgery isn't the cure for Crohn's disease. So it depends on your colonoscopy, actually. If colonoscopy shows that the stricture is inflammatory and if the patient is willing, we have to consider the patient wishes as well. If the patient is willing to go to surgery, then that could be considered, but it has to be clear to her that surgery isn't the end of the road. She will be having medications after. If she decides against surgery, especially if she's a young active lady who cares about her figure, then we can go for anti-TNF alpha.
I think I have a comment, Professor Amini, for this patient.
Yes, I was ambitious. I was going to ask you really, Professor, for your opinion.
You have to do more and more effort to confirm that is an isolated ileal disease. It may be a small bowel disease, may be anal or rectal segment or patch of Crohn's, and now you shift from isolated ileal to, as we said yesterday, ileocolonic, ileoanal, and something like this. Second, if the patient is clear from pus and no obstruction, no stenosis, no small bowel dilation, you have to start even pre-operative. If the decision is to do operation, you have to start the pre-operative biologics, especially anti-TNF, and maintain post-operative biologics, especially anti-TNF. If you use that, it means these patients, the power of healing is bad and maybe suffering from fistula even post-surgery. So you have to assess the conditions pre-operative and post-operative secure with the use of these biologics, and you have previously full confirmation that there is no small bowel or no rectal or no anal or no patchy of Crohn's disease along the colon.
Yes, if I want to extend my question, Professor Izzat, to my opinion, only this patient was exclusively ileal. But even if you go with the endoscope and you see a normal colon, by biopsy, usually he says that there is element of colitis.
No, not the colitis. He should say that he's consistent with Crohn's, and never the conventional term, it is just a colitis. It's not a colitis. There is a data confirming that the patient and the biopsy go towards Crohn's colitis, not towards the conventional colitis we commonly read in the report. And never forget, a lot of patients we have escape surgery when we use biologics in this group. Commonly, we use isolated ileal resection if there is ileal stricture, hindering the response.
Yes, I agree very much with you because besides what you say that stricture is an indication, Crohn's disease is a progressive disease. So what is the guarantee that after you do ileal resection, the disease will not recur in any place else?
Yes,
so
that is
I really
what I said. Yeah, the pre and post-operative biology.
Thank you very much.
May I add something, Dr. Amani?
Yes, Professor.
I think Dr. Izzat also meant that you have to confirm that there is no other involvement in the small intestine or an upper GI, not only the colon, because maybe if you have only ileal disease, that's fine. Fibrostenotic the surgery might help, but if there is extensive small intestinal disease, I think the surgery is not the solution. We will end up with the short gut syndrome.
Dr. Negah, are you ready to any question now?
Yes, I have a question, please, Professor Izzat.
Yeah, go on.
Professor Ishtawi, you are most welcome in our 5th wave of RBD EDU.
شكرا يا باشا.
شكرا. I think you talk about the selective surgery or elective surgery, which means patient with stricture Crohn's or fistulizing Crohn's in remission, or you are inducing remission by surgical procedure. But what about patients that go for emergency surgery? Patient that is Crohn's, neglected for years, not diagnosed, going for severe inflammation, transmural, peritonitis, perforation, and doing colostomy. What is the post-operative care? Antibiotics, anti-TNF, when to give anti-TNF, and the antibiotic use for how long post-operative? We face many cases like this, and I need to know, or I need to discuss together what is the best medication to deal with these cases.
Thank you very much for your complicated and practical question. So what we do here actually is we discuss with our surgical colleagues. We usually, of course, they will follow the patients with supportive treatment and antibiotics. We, once the patient is discharged, we give them metronidazole. We start them straight away on anti-TNF alpha as soon as they are well enough, and as soon as we are sure that there is no wound infection or any collection in the abdomen. I don't know what people in Egypt do, and I'm willing to hear.
Just a small comment, Dr. Negah, we have to differentiate between just fistulizing with pericolonic or pericolic or periileal collection or rupture gut. The patient with pericolic collection, commonly you start antibiotics for about 3 months, metronidazole, Cipro, and you can start after clearing of this pus collection and not before the use of antigen. Otherwise, if the patient in a rupture gut and open an emergency and the biopsy said he's a Crohn's disease, now he should start from just 4 weeks post-surgical, the induction and maintenance of the biologics, and commonly we use anti-TNF. And even so, put the patient for follow-up, we're using antibiotics the same duration, at least 1-2 months, with commonly used metronidazole and ciprofloxacin. I think there is a matter of discussion about this.
I agree with you, Professor Izzat. I talk about the patient with rupture gut.
Yes.
And I think we give anti-TNF as soon as possible we can. When he do surgery and given antibiotics for 1 or 2 weeks, his parameters of septicemia and the peritonitis declining, we have to begin anti-TNF as soon as possible. But I wanted to ask you a question. In these cases, do we begin with the standard dose 5 mg per kg, or you prefer to raise the dose up to 10 milligram per kg?
In this patient per se, they do a proactive assessment of TNF level, that is anti-TNF drugs. This is one of the risky group of patients not using the proactive, the reactive assessment of the drug. We commonly give him the anti-TNF in the standard dose and taking a blood sample after every 2 weeks for assessment of the drug level. Because when escalates the dose here, it's a risky patient not to start by 10 milligram. It's better go on 5 milligram per kilogram body weight, but you have to use it combined with immune modulators as we commonly use. And this highly indicated for proactive anti-TNF drug level assessment and antibody.
Yes, I agree with you. And we go for the standard dose combined with immunomodulators and also antibiotics for 2 to 3 months. Thank you.
Thank you. Shifting for the next session, please.